Stop screen share. There you go. Okay, very good. Okay, we'll move on with Stéphane Gautagny, a neurosurgeon from Paris, France. Welcome, Stéphane.
Yes, thank you.
Yeah,
I'm very happy to be with you. Can you hear me?
Yes. Can you please introduce yourself before you go into your presentation, and welcome.
Yes, my name is Stéphane Gautagny. I'm working in Paris in Beaujon Hospital. I'm a neurosurgeon mainly focused on hydrocephalus and NPH. My presentation today is about how to perform ventricular atrial shunting under local anesthesia for normal pressure hydrocephalus. Let's go. The diagnosis of normal pressure hydrocephalus is challenging, as you know. I won't explain all that in detail, but we rely on clinical examination, imaging, CSF infusion test, and CSF tap test to select patients. And there is no gold standard for treatment. Shunting is the treatment of hydrocephalus, and we use ventricular atrial shunting. It is a simple procedure. I will show it to you without additional morbidity. It has been published recently. General anesthesia in elderly people has been associated with cognitive decline, and this is exactly the opposite goal than the one we want to reach in NPH patients. That's why we try to avoid general anesthesia complications by using local anesthesia. It is possible because VA shunting is not a very painful procedure. Before describing the procedure in itself, I would like to emphasize a few tricks that might be helpful, and that is basically what we are doing. We do believe that the correct positioning of the ventricular catheter is crucial for long-term efficacy of shunting. We use a parieto-occipital approach to enter the occipital horn and point to the frontal horn to be away from choroid plexuses along the long axis of the lateral ventricle, so that the number of holes of the ventricular catheter inside the ventricle doesn't change according to the size of the ventricle. We do think that the use of neuronavigation improves the accurate placement of the catheter. The next two slides describe the imaging criteria in NPH we use. I will not describe all that, but you can read them afterwards. The type of anesthesia when we want to avoid general anesthesia is the use of a sedation by remifentanil. Remifentanil is a short, rapid-action opioid analgesic that can alleviate pain and anxiety associated with the procedure. Remifentanil is administered IV using a target control infusion that is started ahead of painful steps. The main side effects are transient respiratory depression and nausea that has to be prevented systematically. We use local anesthesia with lidocaine. It is very important to have an atmosphere of positive communication with patient, with a quiet environment, and the whole team involved in those anxiety-providing procedures under local anesthesia. And we systematically use antibro prophylaxis, targeting Staphylococcus and the Propionibacterium acnes. We use a programmable valve that decreases the need for surgery when dealing with under or over drainage, implanted in high pressure and then decreasing steadily to the best pressure needed by the patient. And there is systematically an antechamber used to allow tapping and testing of the shunt. Let's go through the main surgical steps. First of all, positioning. The patient is lay in a supine position with a pillow under the right shoulder. The head is turned on the left side. I think that VA shunting is an exception in neurosurgery because the patient lay flat or even is tilted back to ease the jugular visibility. That's exactly the opposite of what we do in normal neurosurgery. We use, as I told you before, neuronavigation for the accurate placement of ventricular catheter, fluoroscopy, I will show you why later on, and ultrasonography. We have to set up everything before the surgery. let's go through the main steps of surgery. First step is localizing jugular vein with the use of ultrasonography. It is very easy to do that. At the beginning of your experience, you can ask the anesthesiologist to help you. They are doing that every day, and they can show you how to do that. And very shortly, you will become fully autonomous with that. When you compress the jugular veins, it disappears while the carotid artery stays patent. The local anesthesia is applied in two steps. First, local anesthesia for the pins of the head holder. We use a head holder for two purposes. First, for the use of neuronavigation, and the second is to avoid any unexpected movement during surgery, and especially when we pass the catheter to the cervical area. And the second, so it needs anesthesia on each pins of the head holder, and also local anesthesia along the skin incision and the jugular point and the path in between. We adapt the infusion of remifentanil to these difficult steps. After scrubbing and draping, the first step is the punction of jugular vein with the help of the ultrasonography. Here you can see the needle, which is in the middle of the jugular vein. You can feel that you are inside the vein because the blood is comes in the syringe. Then you insert the guide wire inside the needle. You check by fluoroscopy that the guide wire is going through the jugular vein and vena cava to the atrium. And you insert on the guide wire a split shift then introducer that has been designed for central venous catheter. And you can then remove the guide wire. The next step is the skin incision. It is performed just a linear incision in front of the catheter entry point to allow the burr hole to be done. Then you prepare a subcutaneous housing for the valve and its reservoir. The next step is to introduce the passer subcutaneously to the cervical level. These steps can be painful for the patient if you do not have injected enough lidocaine, and you can redo local anesthesia if necessary. This is the sweetest part of surgery, of course, as you know. And here you are. Now you just have to introduce the catheter in the passer. The wool system is pre-connected to avoid any disconnection, especially between the valve and the atrial catheter. The next step is to insert the ventricular catheter. It is inserted under neuronavigation. The aim is to reach the ventricle within a single attempt, and precise placement. Here on the screen, you can follow real-time the introduction of the catheter within the ventricle, and the catheter is finally placed in the frontal horn of the lateral ventricle. The next step is to connect the ventricular catheter to the valve with a suture to secure it. You test the valve to be sure that CSF is flowing spontaneously. You can use a syringe or not if it is not necessary. Then you can insert the valve in its housing. And the next step is to cut the atrial catheter to the appropriate length. The ideal location of the atrial catheter is the junction between vena cava and atrium. It can be checked by X-ray, but an easy trick is that usually the optimal length of the atrial catheter is the length of the introducer. So you just show the introducer and cut the catheter. Then you introduce this catheter in the introducer. You can see here the catheter that has been introduced in the introducer, and then you split the introducer by removing it gently and pulling the sheets apart. The last step is just to close the skin incision, just one single suture at the cervical level and classical closure at the cranial level. It is very important not to prick the catheter during closure because it changes the properties of the valve. We systematically perform a CT scan of the brain and chest to be sure that the ventricular catheter has its tip within the frontal horns, going to the reservoir of the valve, and then down to the junction between the vena cava and the atrium. I hope that I convinced you that ventricular atrial shunting is simple and can be safely done under local anesthesia. Thank you for your attention.
Okay, very good. Thank you very much. Excellent. Well illustrated. Oh, I'm sorry. Can you hear me?